First case is a 5-year-old male, status post fall on a trampoline with a right femur shaft fracture. Neurovascularly intact, was closed, reduced, and placed into a spica cast. A 10-year-old female, status post fall from a bicycle with a right type 2 supracondylar humerus fracture. She was neurovascularly intact and taken for a right elbow CRPP. This is a 14-year-old female, status post fall while dancing at a competition with a right Salter-Harris 2 distal radius fracture. She was neurovascularly intact, closed, reduced, and placed into a sugar tongue splint. This is a 14-year-old male, status post fall while playing soccer with a right distal both bone forearm fracture. Was neurovascularly intact, closed, reduced, and placed into a sugar tongue splint. This is a 40-year-old male, status post low speed MVC with a minimally displaced right distal radius fracture. It was neurovascularly intact and placed into a sugar tongue splint. This is a 67-year-old male, status post fall with a left proximal humerus fracture, neurovascularly intact, and made non-weight bearing to sling. And then there was a request to just briefly bring up a case that was presented a couple weeks ago. This was a 15-year-old male, status post a dirt bike injury. He had a right open Salter-Harris 2 distal tibia and fibula fracture that was treated with an IND and ORIF, cannulated screws. I don't know if I know Dr. Katt and Dr. Bowe may have had some more to say about it. This was his 2-week post-op films. Starts to show some healing there, and then 6 weeks post-op was just seen last week. Was taken out of his cast and put into a cam boot and starting PT.
So I'm not sure there's any controversy with how this was treated. Obviously, you need to keep an eye on, whether this is going to go on to a physeal arrest. What do you think the most important things are as far as physeal arrest are there, Jeremy?
I mean, obviously, the paper that we all referenced was the one that you were a part of. That showed, in our data, showed Salter-Harris 2 fractures were actually the highest, had the highest rate of premature physeal closure. Initial displacement as well was a big factor, and mechanism to the higher energy mechanisms were certainly associated with a higher rate of PPC.
Yeah, no, I think that's exactly right. And this had one closed reduction. From what I understand, I was not involved with it.
Correct. Yeah, just in the OR.
Yeah. So, hopefully this will kind of, go on to heal. What did the x-rays look like when they took the screws out, do you know?
So this is the most recent x-ray from this past week.
Oh, okay. So the screws are still in.
Correct.
Okay.
Dr. Bowe, I think there was a question just based on some literature review about interpositional fat grafting and then your personal experience with this augmentation.
Well, yes, I think that there is some literature that talks a little bit about if you have a very significant physeal injury and you're opening this and you remove any periosteum, is there a role for putting a little bit of a fat interposition in anticipation that there might be a partial physeal closure? As I told Brian, I've actually done that twice, many years ago, and neither of them did particularly well, but I can't even recall the names. And I think that for the most part, I don't do that. I think that, you would treat these, like do a close reduction if you get a good close reduction, and that's acceptable. If not, you have to open them and fix them any way you need to. And you just have to be very vigilant about a physeal arrest developing. And if you do see or suspect a physeal growth, early imaging can be helpful. MRs are tough if you have hardware in there. CAT scans are a little bit better, but afford more radiation. If you recognize this early, before you develop angular deformity, then the decision is where the child is in his growth. And if there's a significant amount of growth remaining, then we would try to consider doing a physeal bar resection. And then we would use some interposition material, fat, methyl methacrylate, or whatever you like. And that's been my kind of, algorithm for the treatment of these. So.
And I think if I remember correctly in your paper, very, very few of these kids ended up going on to have a subsequent surgery. So I think that's a key point.
Yeah, I don't remember all of the details, but I think maybe Jeremy knows. I think that there were maybe 15, 16 kids who went on to partial physeal closures. I think we reviewed over 100 of these or close to that.
It was like 150. I think the rate was like 12% or something, which was less than some of the other papers that had been out at the time.
Okay.
But not all of those people that went on to physeal arrest needed subsequent trips to the OR.
Yeah, I think how many had physeal arrest? 15 or?
I think it was 15, yeah.
15.
Something
And
like
of
that.
those, I think that only, 4 or 5 of them needed subsequent surgery. And the majority of those were complete epiphysiodeses. There were 2 that needed osteotomies and physeal bar resections, and both of those actually did very well. So it's not, often that you need to do something, even if a physeal bar occurs, but you need to, be ready to do it.
Thank you.
Good morning. First patient is a 76-year-old male with a left proximal humerus fracture, neurovascularly intact, placed in a sling made non-weight bearing. Next patient is a 54-year-old female presenting after a ground level fall. The left non-displaced olecranon fracture. Patient was neurovascularly intact and treated non-operatively, a splint placed in about 40 degrees of extension. Next patient is a 24-year-old male presenting after a fall off of his bike a few days prior to presentation with a right small finger metacarpal neck fracture. Patient was otherwise neurovascularly intact, placed in an AP slab splint. Next patient is a 26-year-old male presenting after a motor vehicle collision with a right hip dislocation and posterior wall acetabular fracture. Patient was close reduced in the emergency department, and CAT scan was obtained to further assess the joint, and showing a right posterior acetabulum fracture with a lateral and posterior displacement of the fragment. Patient was taken to the operating room for a right acetabulum open reduction, internal fixation. Next patient is a 73-year-old female who fell as she was getting out of the bus, presented with this left hip intertrochanteric fracture. Patient was taken for a left hip intramedullary nail.
Good morning. First, we have a 58-year-old female, status post ground level fall with a left zone 2 fifth metatarsal base fracture. She's placed into a short cast and made non-weight bearing.
How did that happen?
So she was wearing like a 2-inch platform shoe, and she sort of sounds like she had like an inversion injury, and she probably adducted the foot.
What's your plan for managing?
So I'll keep her non-weight bearing for 6 to 8 weeks in this cast, and repeat radiographs without a cast at that time to check for healing. I know that a lot of these end up, taking a long time to heal, and then several of them go on to actually like a non-unit or even just a fibrous union, and they're painful for quite some time for these patients.
Where do you usually, this patient is an acute injury. Did she have prodromal symptoms?
Pardon me?
Did she have prodromal symptoms? This is an acute injury, right?
Yeah. Like, was she like swollen and
No, was she having pain before?
Oh, no, not that she's described.
So I think these, you talk about making this patient non-weight bearing for 6 to 8 weeks for this injury. I would tell you that this is different than the Jones fracture, right? Which more often occurs in an athlete with some prodromal symptoms. They've been having some pain, or maybe they haven't had pain, but you look at your x-ray and you see, what will you see in an athlete?
See probably cortical, like a cortical reaction.
You see some cortical thickening or lateral beaking of the fifth metatarsal, indicating it's an acute chronic injury. And those do struggle to heal. Personally, I'd probably have this take your cast off, put her in a Cam Walker boot, let her be weight bearers tolerated at, and then I bet you this will be, because I think it's a different animal. And I've done it before and it's worked. I haven't had anybody that I said, oh, this is an acute injury, be aggressive with weight bearing and then find out it turns into a non-unit. So just that's how I would manage this patient if they came to my office.
Where do they describe that watershed, Joe, zone for the fifth metatarsal?
Pardon me? You want me to describe it?
Yeah, describe the location that's normally ascribed to the fracture that's a problem.
Yeah, it's the articulation of the fourth and fifth metatarsal. So
The right spot. I mean, that's the area of concern. But again, I just think they're two different fractures.
next we have a right hand dominant 77-year-old female, status post ground level fall with a right distal radius fracture. She was provisionally closed reduced in the emergency department, then taken for dorsal bridge plate fixation in the operating room.
What did you miss as part of your presentation about the patient's exam?
So laterally, this patient had a tension-sided skin tear that was questionably open.
And why did you choose the index metacarpal in this particular case?
So, I think that you can choose either the long or the index. I think that
You really can't do it with the ring, and the small is not an option. So it's really just those two.
Right. And so the discussion was that using the index metacarpal can allow you to have better ulnar deviation sometimes with these injuries.
Yeah, if your problem is you've lost radial inclination, that's a better way to maintain it. Looks pretty good.
Thank you. Next, we have an 18-year-old male, status post getting tackled while playing soccer. He had a twisting injury, sustained his left bimal-equivalent fracture, ankle fracture. He was closed reduced, and the patient elected to follow up as an outpatient to schedule operative fixation for this injury.
What's your operative plan for that ankle?
I think that looking at this ankle, the syndesmosis is the fibula is not reduced in the incisura. So I think that would require lateral plate fixation and then also syndesmosis fixation.
Preference? For your syndesmosis fixation?
You mean like nail or tie rope? Or personally, I don't have a preference. I'll be honest, but the nails tend to break, and although the screws tend to break, and although that tends to not, maybe not actually cause a problem for the patients. They see it and they may, be concerned with it. So perhaps we may, in a younger active individual, may try a tightrope for him.
Screw doesn't always break. You could stop it from breaking, right?
You can take it out before it does, yeah.
Well, yeah, so a young person who's gonna go back to sports, you can almost guarantee, at least in the United States, you can take it out if you use a screw.
Gotcha.
So you don't have to, that's not the downside to the screw.
Next, we have an 82-year-old female, status post-ground fall with a left distal radius fracture. She's closed reduced and placed into a sugar tongue splint. Next, we have a right-hand dominant 11-year-old male, status post-ground fall, stinness right index finger and long finger, P1 Salter-Harris 2 fractures. The index finger was displaced polarly and radially. It's closed reduced and flexion blocking splint is used.
Wouldn't it be better if this 11-year-old was skydiving with his grandmother and she broke her wrist and he broke his finger? Wouldn't that be better? Like ground
That would
level
have been
fall?
It would have been a better story. I told him he needed to come up with one. Next is pardon me. Pardon me, this was a 15-year-old female, status post-ground fall with, she had a ring finger, a left ring finger, P1 Salter-Harris 2 fracture also. She was close reduced, placed into a flexion blocking splint.
Wait, how old was the patient?
She was 13, pardon me. Thank you.
Good morning. There's a 58-year-old male, status post fall on steps with a right both bone forearm fracture. He was initially placed into a sugar tongue splint and then taken for a both bone forearm ORIF.
Good morning. First patient is an 11-year-old male, who fell and sustained this left both bone forearm fracture. He was closed reduced and placed into a sugar tongue splint. Next patient is a 14-year-old male who fell at Taekwondo and sustained this left distal both bone forearm fracture. He was closed reduced and placed into a sugar tongue splint. Next patient is a 75-year-old female who was involved in a high-speed motor vehicle collision, who sustained multiple orthopedic injuries, including a left closed distal humerus fracture. She was neurovascularly intact on this side. She had a right elbow arthrotomy associated with an avulsion of the lateral soft tissue complex. Unfortunately, I don't have images from her initial injury to the presentation to the trauma bay. She was neurovascularly intact on this side as well. She originally underwent an eye irrigation and debridement of the right upper extremity on the first day of her arrival, and then 2 days later went to the OR for a left distal humerus open reduction, internal fixation on the left, as well as a right elbow irrigation and debridement. She was found to be grossly ligamentously lax on the lateral side, as all of her ligaments were essentially avulsed off of her lateral epicondyle. And so she had an IJS implant.
Morning. Patient is a 49-year-old male, status post of motorcycle accident, presented with his right proximal femur fracture, extension to the subtropic region, was neurovascularly intact. Was taken to the operating room for intramedullary nail. Lateral position start.
Good morning. First patient is a 33-year-old male who was pedestrian struck. He presented with his right distal radius fracture. He was initially closed reduced, placed into a sugar tongue splint, and then he was taken the following day for a right distal radius open reduction internal fixation. Next patient is a 21-year-old male, status posed to injury in soccer when somebody fell on him, and he had a left sternoclavicular joint posterior dislocation. He was neurovascularly intact. He initially presented in outside hospital where this was missed, and went to had persistent pains on orthopedist where they noticed kind of deformity, obviously the clavicle on the left, sent him into the ER where he ended up undergoing a CAT scan showing that posterior dislocation. He had no shortness of breath, no problems from a vascular standpoint. He was taken the following day for a closed reduction in the operating room. And he'll be remain non-weight bearing on a sling. Cardiothoracic surgery was available in case of any complications, but it was successfully closed reduced.
How'd you do it?
Put a bolster behind the scapula and just externally rotated the shoulder, and it popped back in. Once he was pretty well relaxed, it was pretty easy.
What I understand.
So Rob, how do you know it's reduced now?
So we got a couple of different shots in the operating room, looking down from the head. I mean, sorry, let me go to the lower left. This one here, was the first one. Obviously, palpably you could feel it. We clearly saw it pop back in when it popped in. And then we were able to palpate along the sternoclavicular joint. It did not, with a little bit of pressure, it did not really subluxate at all. So we felt that it was stable. It's relatively symmetric here. I mean, I guess we could also get a CAT scan on this patient again to look at it, but he had already undergone a CAT scan for this, and we felt on radiographs it looked symmetric and well reduced. I think the ideal view would be kind of an X-ray looking down from your head where you can see posteriorly. We tried to get that in the operating room, but his jaw was kind of in the way. So we don't have it. This is the bottom left is the best view that we have from that angle. But then the next step would be to get a CAT scan to confirm it was reduced. But we were pretty confident based on our reduction that it was in.
Is this a dislocation or Salter-Harris injury?
It's a dislocation. He was, it was a dislocation, frank dislocation. I mean, on the CAT scan, it looked like I don't see a physis at that joint anymore. I know that the clavicle ends last, but I'm pretty sure he's closed there.
Well, I think that's a good point because that physis closes. It may not even be closed. But if it is closed, then it's probably a dislocation, but more times than not, it's actually a fracture through the physis of the medial clavicle there. I've actually done a number of these open, and when you do them open and you clunk it back in, it sounds like it looks and feels like it reduces, and then it pops right back. So and I think it's very, very difficult to know from plain x-rays whether it's actually reduced. So are you going to get a CAT scan to look at it now or not?
There wasn't any plan to get a CAT scan. No, he actually has already left. He was discharged basically same day of this procedure. So no, not the current timeline. But like I said, I think if you were we weren't that concerned, but I guess based on your experience, maybe we should have been more concerned. Maybe it would have made sense to get a CAT scan afterwards, but we didn't at this time.
Those that I've seen that were Salter-Harris injuries were more likely to be stable after being reduced.
I'm sorry, what was that?
His arm after.
Sorry, Deidre, you were breaking up. We couldn't hear you.
I asked if you ranged his arm in the OR afterwards.
Yes, we did. We ranged it. I mean, we didn't overly range it for the concern of getting it to re-dislocate it, but we did move his arm around a decent amount. We did palpate along the clavicle and push posteriorly, and it seemed to be stable.
How are you going to mobilize him?
So they talk about using like a Velpo bandage. I haven't heard that. We immobilized him with a sling. We're going to keep him in a sling for 3 weeks. I think at 3 weeks, you could start to include some more motion of your elbow on the extremity. But since he's a soccer player, I wouldn't allow him to return to sport for at least 3 months.
Did you counsel him not to move his arm around a lot? 'Cause if you
We counseled him before he left.
concerned about
you're
that
right.
in the OR, then he probably shouldn't have moving his arm too much out.
Yeah, I recommended that he not really use that extremity, keep it in his sling basically at all times until he follows up in the office in 1 to 2 weeks. But that he's going to be really not using that arm for a couple weeks as well. Next patient is a 37-year-old male, status of a motor vehicle collision. He presented with a C4, C5 unilateral left side facet dislocation, kind of a perched facet, as well as a left facet fracture. He was neurovascularly intact. He had no upper extremity weakness, negative Hoffman's. He underwent an emergent MRI that night, showing no real injury to the spinal cord with some mild cord, some being tight at that interspace, but no cord compression. And then he was taken the following morning for a C4, C5 closed reduction and anterior cervical disc fusion. We were prepared to go front back, but he ended up being closed reduced well with when we put on the halo traction. He'll also be treated with an Aspen collar for a couple weeks. Next patient is a 36-year-old female, status post MBC. She presented with a right type 3A open patella fracture, about a 12 centimeter anterior wound over the patella. She also had a medial malleolus fracture on the ipsilateral side, as well as 2nd through 5th metatarsal neck fractures. She received ANSF and tetanus and was irrigated in the trauma bay. And then she was taken about 6 hours later for a right patella IND overreduction internal fixation with this Synthes mesh plate, as well as a right medial malleolus open reduction internal fixation. The metatarsals will be treated non-operatively. Next patient is a 21-year-old female who sustained a gunshot wound to the left knee. Entry wound was kind of lateral and posterior, and the bullet obviously, there was no exit wound. She presented with this left femoral condyle fracture and a retained foreign body. She was neurovascularly intact. She had a CTA that was performed by the trauma team showing 3 vessel runoff. We got recons of the knee showing kind of this lateral condyle fragment. She received ANSF and tetanus, and then was taken the following day for an IND, a removal of that foreign body. And then we probed the lateral condyle. It seemed to be a little bit loose, so we did an RAF the lateral condyle.
At what point can you start bending the patella when you put that plate on?
So when do we bend the, like in timeline, or I mean, we did check the stability of it afterwards,
No,
but I think
when can she start moving it therapy wise?
so. I know it has a little bit of increased stability. I mean, it was multi-fragmentary. I would imagine, I'm not 100% sure, but I think I would still keep her immobilized in extension close to 4 to 6 weeks, and then allow her to start ranging her knee a little bit more.
No, she'll start moving at 2 weeks, but only because of she had a stellate kind of ripped open wound that we took some time fixing. So I would want the skin to heal before letting her move. But with that, with plating, I would normally, if you maybe had a straight transverse incision, maybe just wait a week and start having to move a little bit, because we went there to 90 and it was fine.
Yeah. we did range her in the OR and there was no problem. So. Next patient is a 77-year-old male who had a mechanical fall. He presented with a right intertrochanteric hip fracture. He was admitted, medically optimized, and taken the following day for a right hip intramedullary nail. This patient is a 77-year-old female who presented with left hip pain. She's had this chronic left femoral neck fracture. She is a minimal ambulator, secondary to a prior history of a CVA. Was left her a left-sided weak. She's also has a history of significant chronic steroid use for severe bullous pemphigoid. She's nonverbal, she's bedbound, and per her family, she ambulates with kind of maximum assists very rarely. The decision was made to take her for a left femoral head mastectomy, or essentially a girdle stone procedure, and that will be her definitive treatment. Thank you.
You know, Rob, just to be the devil's advocate, I can understand non-operative management, but why don't you just leave it as it is? What's the benefit of doing an operative procedure in a high-risk patient to remove that portion of the femoral head?
You know, I think while, you know, she's nonverbal, her family did say that they know when she's in pain or when she's nervous, she shakes. That's why they brought her into the hospital, because she's been having more frequent episodes of kind of seemingly to be in pain. So, you know, I think it's hard in someone who's nonverbal to be able to kind of assess their pain status, but I think it seemed to be uncomfortable for her. I think a girdle stone procedure has a better kind of a decent track record of not being very painful afterwards, you know, better pain management. So I think in terms of this, we thought this would be kind of a more conservative approach rather than putting an implant in with risks of infection or dislocation in a demented patient, but also kind of treating the pain that she seemingly seemed to be in.
You said she's a non-ambulator?
Minimal, very minimal ambulator. I mean, per her family, she seems to, they assist her in getting up sometimes from the bed to a chair to the bathroom, but for the most part, she's close to non-ambulatory status.
I mean, you make a great case for doing a girdle stone versus a hemiarthroplasty, but I don't know. I think Brian's right. I mean, why would you even operate on this person?
I said, I think we were treating what seemed to be a kind of a painful chronic hip fracture, but yeah, I think that was the main point for treating this.
Morning. First patient is a 47-year-old female who's involved in MVC with a Scalliozzi fracture. Was taken the following day for radius ORIF, and the DRUJ was tested after the plate was put on. It was stable. Next was a 17-year-old male who's sustained this right SC joint posterior dislocation after a hockey injury. He was initially diagnosed at an outside hospital and transferred here. They didn't have great x-rays, so this is actually the scout from CT. He underwent an open reduction in the OR with some capsular repair.
How did you repair the capsule, by the way?
What?
How did you repair the capsule on that? I'm curious.
Just a few sutures and what was left. There wasn't a lot of capsule. We actually got this closed. It was a closed reduction. However, he had been taken to the OR the previous day with a failed closed reduction. And while it was not a very satisfactory closed reduction, we didn't feel a great big clunk. There was maybe the x-rays were showing that it was likely reduced, but the fact that he had already failed one closed reduction in the operating room, we felt it was prudent to open this just to confirm. And then we just basically threw a few sutures in the capsule. It was stable after we opened it as well. So he's 17. There was a little physeal fleck, but it was not a Salter Harris. Yeah. Yeah. 5. Yep. 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 We had actually both CT surgery and then CT surgery felt uncomfortable. So they also consulted vascular on backup. So we had both on backup, unlike the one that Rob presented about 5 minutes ago, where they just had CT surgery. Yeah. Yeah, we didn't feel like we needed them, and it was fairly stable once we got it reduced. There was probably that Salter-Harris component to it. But didn't. Yeah.
Stable anyway.
It was stable anyway, and I mean, if we had been very confident in our closed reduction, it had been our first trip to the operating room. It was not his second trip. We would have left it just with the closed reduction, not opening it.
I'm going to make a comment, just and maybe echoing something Dr. Bowe said earlier. My phone was cutting off, but of these that I've done closed, I've almost always used a towel clip on the clavicle because you could just control it better and know where it is, and you can get a sense for it subluxating back, which they pretty much all do. The ones that I've done open, I find that there's no capsule to repair. If you were able to find capsule, bully on you, that's fabulous. But more often than not, it's a tendon graft and we're wrapping it around. And even then, it still sags posteriorly a little bit, but at least you feel like you've wrapped some collagen around it. I don't know. I mean, there's no difference between the ones that I've done open and the ones that I've done closed. The ones that I worry about are the ones that redislocate fully, and they're just not that common, but it can happen. So that's my 2 cents.
Next was a 40-year-old gentleman who's involved in a motorcycle collision, his left tibial shaft fracture. He was provisionally splinted and taken the following day for a left tibia I am now. Thank you. That would be it. Thank you.
I am purchasing